I'm talking about developing standardized titles to classify adverse events in neurosurgery. Um, so, so the background of this is that, in neurosurgery, we encounter adverse events just like any other specialty. But those adverse events can cause permanent neurologic deficits with significant decrease in quality of life. And they are always discussed at a monthly held M&M conference, which is an important portion of improving care and reducing harm. And then we come up with solutions on how we want to prevent a certain adverse event. But there are several issues with that to actually achieve a sustained improvement in the quality of care that's provided to patients. So the first thing is the definition of what constitutes an adverse event and an M&M is not really standardized. So a lot of the times it's dependent on what the chief resident thinks is an adverse outcome, but it's not clearly defined. Now, at the same time, we put everything in Excel sheets and also in PowerPoints, and we present it to the whole department, but it's also not consistent as far as what we name an adverse event. So I'll get to why that's important a little bit later. So, but just to give you a few examples, just a simple thing that we can encounter in the operating room, like a CSF leak during a lumbar laminectomy or a fusion procedure, can be named several things. It can be, a durotomy, it can be CSF leak, dural tear, and so forth. So we wanted to actually standardize the naming and also what constitutes an adverse event, because the measures that are discussed at those M&M conferences are usually not carried forward beyond that conference in that, one morning in 1 month. And then, 3 M&Ms from that, then we'll be discussing the same issue, and then we'll come up sort of with similar solutions. But did we actually avoid the occurrence of that adverse event? That's not known. The hypothesis was, so we reviewed our data, and the hypothesis was that an adverse event has to be clearly defined and reported each time it occurs, and that the majority of adverse events that occur in neurosurgery can be defined using a specified naming pattern or nomenclature that can be used every time, and then that way we can look at it in a standardized way. So we reviewed our M&Ms and the adverse events that occurred over 2 years, and we defined it as any mortality, any unintended or undesirable event, and any event that prolongs the patient's hospital stay, or an outcome that results in transient or permanent neurologic deficits. So we intentionally kept it very broad, and to make sure that we capture most of them, and at the same time we can make sure that most of those events can be captured using a certain term, and I'll show you what I mean by that. So what we did then, we categorized those adverse events into the 3 divisions or 4 divisions that we have: tumor, vascular, spine, and functional. And the results showed that we had 7,418 cases over the 2 years that of the study period or the QI project. And we identified roughly 1,000 and 1,100 adverse events. So you can see the breakdown here. 418 were in vascular, 249 were in tumor, and 429 were in spine and functional. So the most common ones that we found were infection, hemorrhage, and CSF leak or durotomy. And other adverse events that we also captured were not related to the procedure itself, just a, like a DVT in stroke patients or a pneumothorax from central line placement or other issues. So, and those are the standardized titles that we developed. And this is probably, one of the most important slides. So you can see that here are the divisions that we have. And then those are the categories that, 99% of the adverse events fell into. And you can see that you can summarize them, if there is a seroma and a fluid or some, fluid collection under the wound, then this is the naming that should be used. And if there is an infection, it can be, a wound infection. It shouldn't be expressed and captured in 5 different ways. It should just be called wound dehiscence or a wound infection, which you see below. And the way that we restructured the capture of the M&Ms is using this spreadsheet that essentially will have the chief residents capture the M&Ms in a similar way that they used to do before. So with MRN, age, sex, and all of that, the admission date and diagnosis and the surgery that they had. But this column shows you the standardized M&M nomenclature where you can pick the right one from a drop-down menu. Now, if there is an M&M that is not captured here, and it's something maybe, completely out of the ordinary, then there is another category that's just called other. And then if that adverse event occurs more frequently, then we can add a naming, like a title, to this drop-down menu. So in addition, the PowerPoint was also restructured on how it should be presented. So here we'll have the patient, the indication that was the surgery done for, what the adverse event was, and what should be done to improve this case. And this just gives you an example here of how they should be structured. So the advantage of this is then once we have all of this data that's already been captured, once we have it in a standardized fashion, then we can actually query the database, and then we can find those adverse events from any given time, and then we can look at patient specifically, patient risk factors, surgeon, hospital, and all of those things, and see if we can actually find predictors that made it more likely that this patient had an adverse event, and see if we can actually prevent and modify some of the risk factors in the future. So the take-home message here is that adverse events in neurosurgery can be described using those titles that we showed, and it allows for better capture and recording, so we can actually define risk factors for patients. And that way we can actually also measure the success of interventions that we do, because then we can track those adverse events over time and show that their occurrence decreased over time. And I'll be happy to take any questions.